Hello, my name is Dr. Paul Richardson and I'm the Director of Clinical Research at the Jerome Lipper Multiple Myeloma Center, Dana-Farber Cancer Institute in Boston. The potential points for intervention in VOD are several, and I'm seeking to summarize them here. First is identifying risk, which may or may not be physically possible in the context of hematopoietic stem cell transplantation for hematologic malignancy, but certainly is an appropriate strategy to consider. The second is targeting cell injury with a variety of strategies that have some mixed evidence of benefit. Obviously, targeting inflammation is a logical next step, but again, this can be challenging in the context of various immunosuppressive effects. But what's particularly of interest is targeting microthrombosis and fibrosis. And in this regard, Defibrotide has emerged as the best candidate agent in this setting, recognizing that once necrosis is established, supportive care follows, and in this respect, obviously, targeting the process upstream, particularly in the context of microthrombosis and fibrosis, is clearly a preferred approach in reversing the process from the start. Now, Defibrotide as an agent has emerged as the FDA-approved, only FDA-approved and EMEA-approved agent for the treatment of severe VOD, SOS with multi-organ dysfunction. And in this regard, it's worth sharing with you some of its properties. First, it's a polydispersed oligonucleotide, a first-in-class agent that exerts protective effects on the endothelium. Second, the use of Defibrotide for the treatment and prevention of VOD has been supported by various clinical trials, including data from phase 3 studies. The proposed mechanism of action of Defibrotide is complex. It is, however, proposed to involve two distinct elements: protection of the endothelium and restoration of the thrombotic fibrinolytic balance. Defibrotide has been shown to decrease the influx of inflammatory mediators, specifically through the downregulation of ICAM1 and heparinase, and also to activate the fibrinolytic system, which is particularly relevant in the context of microvascular injury. This next diagram seeks to summarize that for us to show where Defibrotide specifically interacts and interfaces with the sinusoidal endothelium and the subendothelial matrix. Now, there are a number of key clinical trials that show the benefit of this approach in the treatment of severe VOD and multi-organ failure, and they're summarized here, ranging from the initial early phase 1-2 work in the late 90s, early 2000 period, where we were able to demonstrate consistent signal of complete response across large cohort studies of patients with a consistent signal of day+100 survival, which is substantially better than expected, and with an excellent tolerability profile. A randomized phase 2 trial was very helpful in identifying an effective dose, and in this study, day+100 survival again was highly impressive at 42%, with treatment-related adverse events being uncommon, just 8%. The overall complete response rate was 46%, with an effective dose of 25 milligrams per kilogram per day identified. The subsequent phase 3 studies using historical control methodology as well as the treatment IND further have established the effectiveness of Defibrotide compared to historic controls and its impact on mortality. In regards to this, the treatment IND 2006-05 has been a particularly important asset in terms of an exploration of the efficacy of the drug in the transplant and non-transplant setting. This study was designed to offer access to Defibrotide subsequent to the original phase 3 trial and looked at both patients with multi-organ dysfunction as well as those with not. And in terms of the results, broadly showed that approximately in those patients with severe VOD, overall response rates were around 30%, with higher rates seen in those patients with non-severe VOD. Moreover, the timing of Defibrotide initiation was seen to be important in this particular study. Finally, in terms of the safety profile, this was all as expected in this very high-risk sick patient population, with no evidence of additional or added toxicities seen, other than the observation that hypotension can sometimes be seen and be managed appropriately, and whilst hemorrhage is rare, especially in the life-threatening variety, extremely so, nonetheless attention to coagulation parameters and bleeding risk is important. What was fascinating was to also note that in these studies the rates of all-grade GVHD was surprisingly low, and this led to an important observation that then followed in a subsequent phase 3 study with Defibrotide, where we looked at the prevention of VOD in stem cell transplanted patients in children under the age of 18 years, and this particular study showed convincingly that there was a significant reduction in the incidence of VOD and also an important effect on mortality, which was 4 times higher in patients with VOD than those without VOD. What was also very interesting in this study was a secondary endpoint was a significant reduction in the incidence and severity of acute GVHD, and which has now led to subsequent studies looking at this approach. I want to thank you very much indeed for kindly listening to this presentation, which I hope has been helpful. Thank you again.